Welcome back everyone. Welcome to the third video of our learning tuberculosis journey. First of all, I would like to congratulate everyone who is here because that indicates that that person has watched the first two videos and he or she is interested in learning more and more about tuberculosis so that we can enhance our knowledge and so that we can achieve our goal of ending tuberculosis, which was the theme of this year's World Tuberculosis Day. So today's discussion will be based on extrapulmonary tuberculosis. The outline of today's discussion will be we will be learning mainly about neurological tuberculosis, tubercular lymphadenitis, tubercular pleural effusion, tuberculosis of bones and joints, and abdominal tuberculosis. So first, coming to neurological tuberculosis. Neurological tuberculosis can manifest in a lot of ways, but mainly we are going to focus on two important forms. One is tubercular meningitis and the another is tuberculoma. So first, coming to tubercular meningitis. Tubercular meningitis is the most severe form of tuberculosis or extrapulmonary tuberculosis. It is the most severe form of all forms of tuberculosis that one can encounter. It occurs mainly in 6 months to 4 years of age. One can remember the Walgren's timetable we learnt. Neurological tuberculosis mainly manifests in the 3 to 12 months after the primary tubercular infection. It has 3 stages of clinical presentation that we are going to learn today. It progresses over weeks usually. It may progress rapidly in infants and young children. And the prognosis depends upon the stage at which the treatment begins. The earlier the treatment begins, the better the outcome. And the other form of neurological tuberculosis is tuberculoma. Mainly it presents as an intracranial space occupying lesion. And it presents as seizure, headache and focal neurological deficit just like any other intracranial space occupying lesion. So now coming to one of the most important exam viva questions that is usually asked in pediatric final exams or even medicine final exams, MD final exams or DNB final exams. What is the pathogenesis of neurological tuberculosis? First pathogenesis is meningeal exudates. TB is famous for forming meningeal exudates or basal exudates at the base of the brain which extend into the brain. Second is it can obstruct the CSF pathway at multiple levels leading to hydrocephalus. The obstruction can occur at multiple levels such as interventricular foramina, aqueduct of Sylvius, foramina of Luschka, foramina of Megendi, basal cisterns, and hydrocephalus is one of the most common mechanisms of brain damage causing myelin depletion, axonal degeneration and neuronal fallout, initially in the cerebral white matter and later in the cortex. Third mechanism is involvement and occlusion of large vessels in the circle of Willis and that of middle cerebral artery in the sylvial fissure by the exudates, which lead to ischemia in return, which lead to stroke-like manifestations. Fourth is complete occlusion of vessels leading to infarction and surrounding edema. Fifth mechanism is lenticulostriate artery occlusion, which can lead to lacunar infarct and localized encephalopathy like manifestations. Engulfment and or destruction of cranial nerves, mainly 2, 3, 4, 6 and 7. Border zone encephalitis. Ventriculitis, mainly subpial or subependymal necrosis. Choroid plexitis, that is inflammation of the choroid plexus. Generalized edema and microscopic hemorrhages due to microangiopathy. Involvement of veins with hemorrhagic infarctions and thrombosis, and damage to motor roots caused by exudates or immunological mechanisms. So these are the 12 main principal mechanisms by which the neurological tuberculosis occurs. That means the tubercle bacilli, by causing all of these mechanisms, involves the neurological system and hence leads to the clinical manifestations that we are going to learn now. So as we discussed, the stages of tubercular meningitis happen in 3 stages. The first stage, in the initial stage, the first stage, there are non-specific symptoms. In the second stage, there are signs of meningeal irritation and raised intracranial pressure. And in the third stage, there is signs and symptoms of generalized brain dysfunction and severe increase in intracranial pressure. So this is the 1, 2 and 3 stage. First stage is non-specific symptom. Second stage is signs of meningeal irritation and raised intracranial pressure, and the third stage is generalized brain dysfunction and severe increase in intracranial pressure. So from this, if we remember this much, we can extrapolate all the symptoms. First stage, non-specific symptoms. So what are the non-specific symptoms? Fever, headache, irritability, drowsiness, malaise, anorexia, inadequate weight gain or weight loss, and stagnation or regression of developmental milestones. So some forms of neurodegenerative disorders or post-infective demyelinating disorders can also have confusion in diagnosis like this. So initial stages may overlap. Non-specific symptoms are seen in the first stage of tubercular meningitis. Second stage, signs of meningeal irritation and signs of raised ICP. So what are the signs of meningeal irritation? We know that nuchal rigidity, lethargy, Kernig sign, Brudzinski leg sign, Brudzinski neck sign, and signs of raised ICP like seizures, hypertonia, vomiting, and cranial nerve palsy, basal meningitis, and other focal neurological deficits. Last stage, that is third stage, generalized brain dysfunction and severe increase in intracranial pressure. So what are the symptoms that the patient will have? The patient will have coma, hemiplegia, paraplegia, decerebrate posturing, decorticate posturing, and deterioration in vital signs. So these are the stages by which the stage of the tubercular meningitis progresses. And as discussed earlier, the earlier we intervene, the better the outcome. If we intervene in the stage 1, the patient will improve more. If we intervene in stage 2 or 3, the chances of recovery will obviously be less than if we have intervened in the stage 1. So what are the investigations in tubercular meningitis? Obviously, as in any other form of meningitis, we will have to do CSF study. So CSF analysis will show gross appearance will be clear, but sometimes upon keeping the CSF steady, sometimes we can see cobweb appearance. Leukocyte count will remain between 10 to 500 cells per cubic millimeter, which will be lymphocyte predominant. Glucose will be low and CSF to blood glucose ratio will be less than 0.5, just like any pyogenic meningitis. Protein will be more than 100 mg per deciliter. The normal is 15 to 45, and rapid NAT positivity in CSF is 30 to 40%. As you can remember from the last lecture, in the microbiological tests of tuberculosis section, the pleural fluid, CSF, synovial fluid, all these ascitic fluid, all these samples or all these biological fluids have very low yield or low sensitivity for nucleic acid amplification tests. So among all the cases of tubercular meningitis, only 30 to 40% will have NAT positivity if we send the CSF sample. Tuberculin skin test is reactive in 50% of cases. So as discussed earlier, tuberculin sensitivity test only, tuberculin skin test only indicates a positive contact history or a past infection in the person. No, it does not indicate any active disease, and chest X-ray abnormalities are seen in 20 to 50% of cases of tubercular meningitis. That means in 20 to 50% of cases of tubercular meningitis, a primary focus in the lungs may be identified. So now coming to the neuroimaging findings, these are the CECT brain findings: basal meningeal enhancement, hydrocephalus, tuberculoma, cerebral infarcts, especially basal ganglia, and pre-contrast basal hyperdensity. All these are seen in the contrast enhanced brain findings. We'll see some of the images later. And as a whole, contrast enhanced MRI is better than contrast enhanced CT scan, and all these findings in the neuroimaging can be seen in some other conditions also. So which are the differential diagnosis of neuroradiological findings? These are cryptococcal meningitis, CMV encephalitis, toxoplasmosis, sarcoidosis, meningeal metastasis, and lymphoma. That means all these conditions can also show some of these features. So we have to think about these diagnoses also when we get all these features in neuroimaging. Now coming to one neuroimaging finding. So this is the image of a brain. Can you tell this is CT or MRI? This is a CT scan because the bone is white. If the bone is black, we would have told this is an MRI. So this is a CT scan. This is the axial section of brain, and this is the right side, this is the left side, and this is the anterocranial fossa, and this is the posterocranial fossa. Can you see there is a 1 into 1.1 centimeter round hypodense lesion in the right frontal lobe, and there is dilatation of all the ventricles. These are the lateral ventricles. This is the septum pellucidum, cavum septum pellucidum. All these are dilated, and these are the basal cisterns and cisterna magna. All these are dilated. And if we give contrast, this is a contrast enhanced image. Why I am telling contrast enhanced? Because I can see contrast in all the sulci. Gyri and sulci, I am seeing the contrast material. and there is contrast enhancement. See the lesion here, see the lesion here. There is contrast enhancement. So post contrast ring enhancement. So this is classically seen in tubercular meningitis or tuberculoma. So now coming to, I think, which is the most important slide of tubercular meningitis that every resident needs to remember or needs to understand. Why? Because this is the diagnostic algorithm. We are going to discuss the diagnostic algorithm of tubercular meningitis. That means when and how we will suspect tubercular meningitis in a child, and if we suspect, how we will evaluate and how we will manage. So first we have to suspect TB meningitis in a particular person. Like in presumptive pediatric TB, how did we suspect? Fever persistent for more than 2 weeks, cough persistent for more than 2 weeks, failure to gain weight or significant weight loss, positive contact history, no improvement despite of nutritional rehabilitation in severe acute malnutrition. From all these criteria, we suspected that the patient might be a case of presumptive pediatric TB. Just like that, we have to suspect TB meningitis if insidious onset of fever and neurological abnormality with or without all these clinical features: headache or vomiting, poor feeding or weight loss, irritability or lethargy, seizures, coma or confusion, neck stiffness, cranial nerve palsy, hemiparesis. All these features are there. If any of these features are there, we have to suspect TB meningitis. And when we suspect TB meningitis, next what we will do? We have to immediately evaluate by doing these investigations. What investigations we will do? We will do chest x-ray, tuberculin skin test, CBC, liver function test, random blood sugar, contrast enhanced CT scan of the brain, HIV testing as offered to all suspected TB patients, CSF study in form of cytology, AFB staining, biochemistry, CBNAT, MTB and pyogenic culture. All these things we have to do. Basing on these investigations, we will receive a report. And then we have to see, are acid-fast bacilli seen or nucleic acid amplification test is positive in CSF? Think, if the acid-fast bacilli are seen in CSF, that means microbiologically confirmed neurological TB. If nucleic acid amplification test is positive in CSF, that means microbiologically confirmed neurological TB. So then what? We have to start treatment right away. So if all these things are positive, that means AFB is seen on CSF or NAT is positive for CSF, then we have to start treatment right away. Start treatment for TB meningitis. Our diagnosis of TB meningitis is confirmed microbiologically. That is the best diagnosis. But suppose these investigations come negative, then what we will do? Then what we will do? We have to check for following 3 criteria. This is the most important step. What are the 3 criteria? So there are basically 3 criteria. These are the 3 criteria. First criteria is clinico-investigative criteria. Second criteria is risk factor criteria. Third is evidence of TB elsewhere. So what are the 3 criteria? Again, criteria 1 is clinico-investigative criteria. That means some clinical features are there, some investigation features are there. Basing upon that, a criteria is there. Second is risk factor criteria. That means some risk factors are there, and basing upon those risk factors, some criteria are there. Third is evidence of TB elsewhere. That means if we find evidence of TB anywhere other than the CNS, that criteria is considered positive. So what is the first criteria? If more than 3 criteria among these 6 are present, it is considered positive. So what are those 6 criteria? First is, have the symptoms been present for more than 5 days? Any symptoms, be it fever, be it cranial nerve palsy, be it neck stiffness, anything. If the symptoms have been present for more than 5 days, if the TLC is less than 15,000 per cubic millimeter, if the CSF TLC, that means CSF leukocyte count, is 10 to 500 per cubic millimeter, if the CSF lymphocytosis is more than 50%, CSF to plasma glucose is less than 50%, or imaging evidence of tuberculosis like basal meningeal enhancement, hydrocephalus, cerebral infarct or tuberculoma. These are the 6 criteria. If any 3 of these 6 criteria are present in the patient, it is considered criteria 1 positive. Then what are the risk factor criteria? HIV or other immunocompromised, that is 1. Severe acute malnutrition, that is 2. Recent contact with active pulmonary TB, that is 3. So if the person is HIV or immunocompromised, or having severe acute malnutrition, or has patient recent contact with active pulmonary tuberculosis. If any two of these three are present, it is considered risk factor positive or criteria 2 is positive, and criteria 3 when it will be positive if there is any evidence of tuberculosis anywhere in the body other than nervous system. So we have to see whether these criteria are present. Is criteria 1 present? Any 3 of these 6 if there will be present, criteria 1 will be considered positive. If any 2 of these 3 will be present, criteria 2 will be considered positive, and criteria 3 will be considered positive if there is any evidence of TB elsewhere in the body. If more than equal to 2 criteria fulfilled, that means among criteria 1, 2 and 3 any 2 criteria are fulfilled, then we have to think, if yes, start treatment for TBM. That means if any 2 of these 3 criteria are positive, then our diagnosis of tubercular meningitis is confirmed and we have to start treatment with tubercular meningitis right away. But still, suppose more than equal to 2 criteria are not fulfilled, suppose 1 criteria is fulfilled or any of the criteria are not fulfilled, then what we will do? We had suspected originally TB meningitis basing upon these symptoms. That means still a TB meningitis suspicion is there, so you have to keep a high index of suspicion because it is most severe form of tuberculosis. So next what we will do, we will continue workup and management for alternative diagnosis like partially treated pyogenic meningitis. We have to give antibiotics. We will suspect that maybe it is not a case of tubercular meningitis, maybe this is a case of partially treated pyogenic meningitis, because all these features may be present in partially treated pyogenic meningitis also. So we will give empirical antibiotics and we will continue workup and monitoring and management, and review assessment within 48 to 72 hours. We have to review the patient within 48 to 72 hours. We have to consider repeating the CSF study. We have to expand search for TB elsewhere in the body, and we have to consider contrast enhanced MRI of the brain, which is more sensitive and better than contrast enhanced CT scan. So at any point of time, we have to also again see for this criteria 1, 2 or 3. Again review criteria 1, 2 and 3. If at any point of time more than equal to 2 criteria are fulfilled, our diagnosis of tubercular meningitis is confirmed and we have to start treatment of tubercular meningitis. But still again, suppose our criteria are not fulfilled, then does the patient have unexplained meningitis with low CSF glucose and falling GCS and new focal neurological deficit? That means if we have not found a cause of tubercular meningitis till now, or if the patient has unexplained low CSF glucose, deteriorating Glasgow Coma scale, or any new focal neurological deficit, we have to ask this question. If answer to all these questions is no, there is no low CSF glucose, there is not deteriorating GCS, or there is no new focal neurological deficit, then we have to continue investigating and keep a low threshold for starting empirical antitubercular therapy. But if answer to any of these questions is yes, that means there is a chance of tuberculosis, because unexplained meningitis, low CSF glucose, falling GCS, new focal neurological deficit without getting antitubercular therapy. So all these indicate that there is still a possibility that this is a case of tubercular meningitis. So we have to start treatment for tubercular meningitis. So this is the diagnostic algorithm for tubercular meningitis that every resident must remember, because whenever we are suspecting a tubercular meningitis in any patient, we have to come by this pathway. So now coming to the mainly the differentiating features between tuberculoma and neurocysticercosis, because both are prevalent conditions in our country, in our setup. So tuberculoma and neurocysticercosis we need to differentiate because the treatment for both is different. So what are the contrast enhanced CT scan differences and what are the contrast enhanced MRI scan differences? So first, coming to the appearance, the tuberculoma is a more than 2 cm irregular thick outline and marked perilesional edema. So in tuberculoma, the size will be slightly larger, there will be thick outline which is irregular, and there will be severe marked perilesional edema. That means edema surrounding the lesion. But in neurocysticercosis, the lesions will be smaller, less than or equal to 2 cm. The outline will be thin, rounded and regular, not like tuberculoma, and the edema may not be that severe because the lesions are small. Second, what is the location? Tuberculoma can be infratentorial or supratentorial, wherever it can be. But neurocysticercosis is predominantly supratentorial. Infratentorial neurocysticercosis is very rarely seen. And as the tuberculoma is larger and the perilesional edema is more, there will be midline shift more likely in tuberculoma. On the other hand, neurocysticercosis lesions are small, there is variable small amount of edema, so midline shift is less likely. And coming to MRI appearance, the tuberculoma in T2 weighted imaging will reveal a hypointense score. On the other hand, a neurocysticercosis in T2 weighted imaging will reveal a hyperintense score with eccentric dot, and scolex can be seen on FLAIR and DWI imaging, diffusion weighted imaging. If we do MR spectroscopy, tuberculoma will reveal a lipid peak characteristically. This is an important exam question. But neurocysticercosis, there will not be any lipid peak, and the T2 relaxation time will be shorter in tuberculoma, which will be longer in neurocysticercosis. So now coming to this imaging, can you tell whether it is a tuberculoma or a neurocysticercosis? First, the lesion is larger, the outline is thicker, the outline is irregular, there is surrounding perilesional edema, so and there is midline shift also. So what can this be? There is irregular thick outline, more than 2 cm, marked perilesional edema, midline shift. So this is a tuberculoma most likely. Now this image, there is a small lesion, there is no surrounding perilesional edema, there is no midline shift, and the outline is regular. So what can this be? Less than 2 cm, thin rounded outline, minimal perilesional edema and no midline shift. So this is most likely a neurocysticercosis, and a scolex can be seen inside also. So this is neurocysticercosis. So our discussion of tubercular meningitis or neurological tuberculosis is over. Now coming to tubercular lymphadenitis. What is tubercular lymphadenitis? Most commonly involved cervical lymph nodes, mainly jugular, posterior triangle and supraclavicular. This is the most common form of extrapulmonary tuberculosis. Most common age group that it is seen is 5 to 9 years of age. Clinical features are there is progressive enlargement of a node over 2 weeks. The lymph nodes are usually firm, minimally tender or non-tender usually, and there may or may not be any fluctuation. If it is suppurative, fluctuation may be seen. If it is non-suppurative, fluctuation is usually absent. May get matted, the lymph nodes may get matted, and they may form a cold abscess, and they may rupture and form a chronic sinus later on. Gold standard for diagnosis of tubercular lymphadenitis is histopathology, in which epithelioid granuloma and central acellular necrosis is seen. Alternative diagnostic method is fine needle aspiration cytology, which has a 90% correlation with biopsy. So if you can perform biopsy and histopathology, at least perform a fine needle aspiration cytology. See this patient, there is prominent lymphadenopathy in the left submandibular region, and when you perform histopathology in this patient, you can see numerous epithelioid cells and multiple Langerhans giant cell with central acellular necrosis, granuloma, characteristic granuloma. So this is a case of tubercular lymphadenitis. So what is the diagnostic algorithm that you follow in tubercular lymphadenitis? Whenever you find a lymph node of more than 2 cm in more than equal to one site, that means any lymph node more than 2 cm in any site, if you suspect tuberculosis or tubercular lymphadenitis in that patient, first you have to say what? You have to see whether the lymph node is matted, or if there is any cold abscess present, or if there is any sinus present. Matted means multiple lymph nodes will be there, and you cannot distinguish between the individual nodes. They will not be discrete. If they are separable, it is called discrete. If they are non-separable, combined together, it is called matted. Cold abscess means there will be signs of fluctuation. There will be signs that as if the pus is present inside the lymph node, but there will not be any signs of inflammation. There will not be any overlying skin erythema or overlying increase in temperature of the overlying skin or tenderness. The signs of inflammation will be absent. That is called cold abscess. Sinus means there will be a drainage site and punctum, so sinus. So if all these things are present, if macted is present or cold abscess is present or sinus is present, there is high chance that this is a case of tubercular lymphadenitis, because these are characteristically seen in a case of tubercular lymphadenitis. So if the answer to all of these questions or any of these questions is yes, you have to think this may be a case of tubercular lymphadenitis. So I have to think and evaluate in line of tubercular lymphadenitis. And as we just learned, the diagnostic gold standard method is biopsy and histopathology, and FNAC also has 90% correlation with that. So what we have to do? We have to do 5-needle aspiration cytology, send the sample for nucleic acid amplification test or acid-fast bacilli smear, or MGT. MGT is mycobacterial growth inhibitor tube, and the needle aspirator pus from the lymph node or discharge from the sinus is sent for all these investigations. Now, depending on the investigation reports, the things can be, if AFB is detected or they detected on smear, or nucleic acid amplification test is positive, or KGS granuloma is seen. That means if FNAC reveals KGS granuloma, or NAT is positive, or AFB is detected on smear, or MGT reveals that AFB is present, then our diagnosis of tubercular lymphadenitis is confirmed. So our diagnosis of TB is confirmed, and we have to start treating it as a TB case. But on the other hand, if there is no granuloma, non-KGS granuloma, or no AFB is found on the smear, or NAT is negative, then what we have to do? We had thought of tubercular lymphadenitis based upon these features, but the investigation is coming negative. Still we have to keep a suspicion, but we have not performed the gold standard test. So we have to perform the gold standard test. That means we have to perform excision biopsy and histopathology, and if the histopathology doesn't reveal any evidence of tuberculosis, as this is the gold standard test, we have to think that this is not a TB case. If the histopathology reveals a diagnosis of tuberculosis, we have to think that this is a case of TB. So we have to treat accordingly as per the diagnosis revealed by the histopathology. On the other hand, if matting is not present, or cold abscess is absent, or sinus is absent, all these things are there, what we have to think? This is less likely that there is a chance of tubercular lymphadenitis in this patient. So what we have to do? We have to give a 7-day antibiotic course and review after 2 weeks. Can you remember which thing this is similar to? This is similar to the non-specific shadow in the chest X-ray in the tubercular diagnostic algorithm. When there is non-specific shadow, what do? You give a empirical antibiotic which doesn't have any anti-tubercular effect and review after 2 weeks. If there is any persistent shadow, persistent symptoms, you have to think about tuberculosis and give bronchoalveolar lavage or samples from other sites, or think about getting an expert opinion like that. So similarly in this case, you have to give a 7-day antibiotic course and review after 2 weeks, and if there is no response, then you have to again come to this algorithm. So the yield of getting Mycobacterium tuberculosis positive from all these samples is smear reveals in 10 to 15%, culture reveals in 20 to 50%, and NAT reveals in 35%. That is the yield from the samples. So what are the other investigations in tubercular lymphadenitis? You can do an ultrasonography which identifies non-palpable and deep-seated nodes which central hypoechogenicity that might be suggestive of tuberculosis. You can perform a chest X-ray. Patients with peripheral TB lymphadenitis, among these 5 to 40% have pulmonary or pleural abnormalities, hilar or mediastinal lymph nodes, and parenchymal lesions or pleural effusions. That means 5 to 40% patients among all the patients of tubercular lymphadenitis, 5 to 40% of patients have a primary lung focus, and that abnormality can be revealed by performing a chest X-ray. And tuberculin skin test is positive in 70% cases of tubercular lymphadenitis. So one important thing to remember is that reactive adenitis in a child with positive TST doesn't mean TB adenitis. Suppose a 9-month-old child has come to you with cervical lymphadenopathy, and for some reason you decide to perform a tuberculin skin test and it comes positive. A reactive adenitis in a child with positive TST doesn't mean TB adenitis. That I want to focus on, because a reactive adenitis can be seen due to anything. A scalp infection can cause a reactive adenitis. An acute respiratory infection or any infection in the throat or tonsils can cause cervical lymphadenopathy, reactive adenitis. That in presence of positive tuberculin skin test doesn't necessarily mean that this lymphadenitis is TB adenitis. That positive tuberculin skin test may be due to BCG vaccination also, or may be due to some exposure to a contact also, but that doesn't necessarily mean that it is a TB adenitis. So the diagnosis of TB adenitis should not rely upon the positivity of tuberculin skin test in that person. That I want to focus on. Now coming to BCG adenitis. What is BCG adenitis? BCG adenitis means basically a lymphadenopathy that has been caused in response to the BCG vaccination. So this is clinically diagnosed, and it is based upon the temporal relationship with BCG vaccination, which is seen weeks to months after the BCG vaccination. That means weeks to months after giving the BCG vaccination in the left arm, deltoid, left arm, the BCG adenitis appears. So there is a temporal relationship, cause-effect relationship. Second thing is, it is same side as the BCG scar. BCG adenitis is never seen in the right side. It is always seen in the left side. Third thing is, it is usually axillary. Isolated supraclavicular lymphadenopathy can sometimes be seen when BCG is given too high up on the shoulder, and enlarged nodes can be one or more and can be at any or both of these sides. So this is clinically BCG adenitis is diagnosed clinically basing upon these criteria, and the absence of local or systemic signs of inflammation must always be there. If there is any signs of systemic inflammation, or if there is any signs of local inflammation, that may not be BCG adenitis. That may be an infected lymphadenitis, or there may be some other cause. So we have to remember that the incidence of that is 0.1 to 1 per 1000 doses of BCG vaccination. BCG adenitis can be of two types. It can be non-suppurative or suppurative depending on the absence or presence of pus. If fluctuation is present, erythema and edema of overlying skin is present, it is called suppurative BCG adenitis. In case of non-suppurative adenitis, the adenitis resolves spontaneously over few weeks without need for any treatment. So you don't have to treat. But in other hand, the suppurative adenitis, what can happen? The suppurative adenitis can spontaneously rupture. It can give rise to a sinus formation, and the sinus formation can heal by cicatrization later on. So what usually is done in suppurative lymphadenitis is that, suppurative BCG adenitis is that, there is needle aspiration performed. Usually a single time needle aspiration suffices to heal the suppurative BCG adenitis, but in some cases of recurrent BCG adenitis, repeated needle aspiration may be required. So that is all about tubercular lymphadenitis and BCG adenitis, and it is very important to differentiate between the two. Now coming to tubercular pleural effusion. It is very simple. The clinical features will be fever, chest pain, anorexia and weight loss, just like any other case. The pleural fluid grossly when seen can be straw colored with high mononuclear cell count and high protein, and it can form cobweb on standing just like CSF. And the diagnosis is by pleural fluid analysis and nucleic acid amplification test. And just as we discussed before 2 times, the nucleic acid amplification test in case of pleural fluid, synovial fluid, CSF has very low yield, and the pleural biopsy may be needed in some cases when there is diagnosis is not clear from the pleural fluid analysis, and a Cope's needle and Abrams needle is needed in those cases. The Cope's needle or Abrams needle can be seen here. Ultrasonography may be helpful, and the pleural fluid adenosine deaminase level, that is ADA, has unclear role in the diagnosis of tubercular pleural effusion, unlike before. Previously, an ADA level of more than 40 to 60 used to be considered a confirmatory marker in case of diagnosis of tubercular pleural effusion, but as of now, ADA specifically has no role in the diagnosis of tubercular pleural effusion. You can think that if the ADA is high, the chances of tubercular pleural effusion is slightly more, but there is no clear-cut indication that the ADA high means tubercular pleural effusion diagnosis is confirmed. So you have to rely on that less and less. Now coming to bone and joint tuberculosis, that is osteoarticular TB. Bone and joint tuberculosis can be mainly thought of as it can affect joints, it can affect the bone, it can affect the spine, and affection of bone can be extraarticular or intraarticular. The affection of bone and joint in tuberculosis occurs by hematogenous dissemination from a primary focus in lungs, lymphatic glands or mesentery, and it can also occur by reactivation of bacilli which had seeded the bones during the initial mycobacteremia. Some risk factors predisposed for involvement of bones and joints in tuberculosis. Those are malnutrition, any form of immunosuppression, poor sanitation, lack of sunshine and fresh air, and debilitating disease, any form of debilitating disease. So 5 to 15% of all extrapulmonary tuberculosis are bone and joint tuberculosis. Common are Pott spine, dactylitis, arthritis and osteomyelitis, and some uncommon forms are reactive arthritis, that is called Ponsard's arthritis, tenosynovitis and bursitis. Bursitis is in fact the least common. So how does it happen? There is usually a history of trauma, but it may or may not be there. It is questionable, but usually there is a history of trauma which leads to a small hematoma and vascular stasis in that area, which leads to a nidus, which leads to formation of a nidus for settling down of the Mycobacterium tuberculosis bacilli, and after the Mycobacterium tuberculosis bacilli has settled, it forms a tuberculous follicle with cageation, epithelioid cells, giant cells and fibrosis at the periphery, which in leads to original follicles, enlargement of the original follicles and coalescence, which leads to formation of a tubercle. So that is the pathogenesis of formation of tubercular involvement of bones and joints. This later on can lead to lytic lesion in the bone initially, and later on it can heal by sclerosis also, but sometimes the tuberculous pus in the medullary canal can form an abscess, and sometimes it can burst and form a tubercular sinus. So this is the pathogenetic mechanism how a tubercular infection affects the bones and joints. So what is dactylitis or spina ventosa? It is seen in it can affect multiple or consecutive bones. Short tubular bones of the hands and feet are usually affected. The proximal phalanx of the index and middle finger and the metacarpals of the middle and ring finger are the commonest site usually. It has a benign course without pyrexia and acute inflammatory sign, and the X-ray can show a diaphyseal expansile lesion with periosteal reaction and healing by sclerosis. Can you see? Can you spot the abnormality in this case? Can you see here the phalanges, and can you see here the metacarpals? Can you see a diaphyseal expansile lesion in both the cases? Expansile lesion in the diaphysis and periosteal reaction sometimes is seen. Here it can be seen, periosteal reaction is seen, and in long term it heals by sclerosis. So this is tubercular dactylitis. So coming to spinal TB or Pott spine, the thoracic vertebrae are the commonest site, or thoracic spine is the commonest site of Pott spine involvement, followed by lumbar and cervical. It can lead to local or referred pain, local tenderness or deformity, and the risk of kyphosis in later life, especially if children less than 7 to 10 years of age are affected. Fever and other constitutional symptoms are seen in only 1/3 of cases. Sometimes complications like paraparesis appears in 20 to 50% of patients, and severe cases can lead to cauda equina syndrome. Paradoxical upgrading reactions are seen in 15% of cases. What are paradoxical upgrading reactions? We will discuss in the video on treatment of drug sensitive tuberculosis. X-ray, only after 30 to 50% of bone loss occurs, then only the X-rays reveal any abnormality, which are end plate erosion, decreased vertebral height, collapse and narrowing of the discal space, and paravertebral soft tissue shadow. MRI is the most sensitive investigation that can catch the tubercular involvement of spine early on, and it can reveal marrow edema, destruction of adjacent vertebral bodies and opposing end plates, destruction of intervening disc, prevertebral, paravertebral and epidural abscesses. So can you spot the abnormality in this MRI spine? This is the abnormal site. Can you see there is destruction of T4 and T5 vertebral bodies? There is destruction of T4 and T5, near total obliteration of the intervertebral disc space, and there is kyphotic deformity, forward bending kyphotic deformity, and there is pre and paravertebral abscess formation extending into the epidural space, compressing the cord. So this is tubercular spine involvement. Now coming to tubercular arthritis. This is intra-articular spread from a osteomyelitis. Weight-bearing joints like hip and knee are involved in 90% of cases, and these are the most common joints involved. It is usually monoarticular. Any case of monoarticular arthritis, tuberculosis has to be considered in among the differential diagnosis. There is characteristically nocturnal pain, which is the first symptom, which leads to later on local tenderness and restriction of movement. X-rays show soft tissue swelling, osteopenia, periarticular bone destruction and periosteal reaction. The MRI is a very sensitive investigation, and joint fluid aspiration or synovial biopsy if we perform and send for histopathological examination or a culture or NAT, it can also reveal abnormality in some cases, but the yield will be very low. So can you spot the abnormalities here? Can you see the erosion at the lateral aspect of the right femoral head? This is the right femoral head. The lateral aspect, can you see the erosion here? And juxta-articular osteopenia, there is osteopenia juxta-articular here and here also there is osteopenia, and narrowing of the joint space. This joint space is very narrow. So this is the characteristic Phemister triad that is seen in case of tuberculosis. Now coming to abdominal tuberculosis. Abdominal tuberculosis can be intestinal, nodal, peritoneal, visceral and disseminated. The symptoms are usually non-specific and variable like abdominal pain, fever, distension, anorexia and weight loss. The signs can be the abdomen can be doughy, which has ascites, omental mass or organomegaly seen in some cases. Isolated, recurrent or chronic pain without any other symptom usually is not tuberculosis. That means tuberculosis usually presents with pain and other features. Isolated chronic pain without any other symptoms usually is not tuberculosis. USG, contrast enhanced CT scan, CT enterography and barium studies are performed, which are very sensitive for diagnosing abdominal tuberculosis, and the low microbiological yield is there of ascitic fluid as we discussed earlier for nucleic acid amplification test. So what is the abdominal imaging and findings in tuberculosis? CT enteropathy, the findings are called CT enteropathy. The commonest site is ileocecal area. There is uniform and crescentic bowel thickening, contracted and pulled up cecum. Ileocecal angle is distorted and obtuse, and short strictures may be seen which are less than 3 cm in length. On the other hand, if you perform an ultrasonography or a contrast enhanced CT scan, abdominal lymph node with central necrosis is the characteristic feature, which can be conglomerate with peripheral enhancement. Mesenteric thickening more than 15 mm is seen characteristically. Caked omentum may be seen. Multiple space occupying lesions in liver and spleen may be seen, and loculated ascites may be there. Can you spot the abnormality in this case? This is a CCT abdomen axial picture. There is a characteristically lymph node with peripheral rim enhancement. So there is presence of multiple enlarged lymph nodes. These are the multiple enlarged lymph nodes in the mesenteric root and periotic region. The enlarged lymph node with central necrosis with gross lymph node calcification is there. There is gross lymph node calcification. The white spots are the calcification. Can you see in this case? There is tuberculosis of the cecum and ascending colon. Cecum and ascending colon, marked irregular parietal thickening is there with decreased luminal diameter is there. Tuberculosis of cecum and ascending colon. And rectal tuberculosis, which is actually very rare. There is irregular focal thickening with decreased luminal diameter. This is a very rare finding, rectal tuberculosis. So what are the investigations that you perform in abdominal tuberculosis? You can perform USG initially, that is a non-invasive simple test without any side effects. This is the initial modality of choice, and you can see lymphadenopathy, peritoneal thickening, omental thickening, bowel wall thickening and ascites. Basically everything will get thickened. Contrast enhanced CT scan and CT enterography you can perform. It can give adequate cross-sectional imaging. Barium studies are actually the gold standard. It can diagnose stricture, fistulae and erosions. And peritonioscopy can be performed for peritoneal tuberculosis, in which one of these three findings will be there. First possible finding is hyperemic peritoneum with ascites with white military nodules. Second finding is hyperemic peritoneum with ascites and adhesions. Third thing is markedly thickened parietal peritoneum with yellowish nodules and multiple thickened adhesions. That can be seen in peritonioscopy. So what are the key learning points of the extrapulmonary tuberculosis we learned today? First thing is neurological tuberculosis is the most severe extrapulmonary form. TB meningitis is a potentially fatal condition and it needs proper diagnosis and prompt treatment. Histopathology is the gold standard in suspected tubercular adenitis. Tuberculosis should be suspected in all cases of unexplained monoarthritis. And abdominal tuberculosis can often be ignored and mismanaged. A high index of suspicion and proper investigation is necessary for diagnosing and treating abdominal tuberculosis. If you like this video, like, share and subscribe, and the next session will start treatment of tuberculosis, and our first video will be the drugs and treatment of drug sensitive tuberculosis. Thank you.